for attending. Oh, and we have a recording in progress. Thank you all for attending today. This, as we all know, that's why we're here, is a vital issue for the healthcare field for the state of Maryland. And we are, this is one step in a long process, but we are so happy to get it started. My name is Blair Ige. I am the president of the Maryland Patient Safety Center. I am a pediatrician by training, was in primary care practice in Silver Spring for about 14 years before moving to the dark side of hospital administration, where I was the chief medical officer for Holy Cross for 19 years and had the honor to work with Lisa Tenney, another member of this committee, for all of that period. Honestly, since I retired and she kept trying to retire, we still work together. I left Holy Cross right before the pandemic, good timing. But the Maryland Patient Safety Center found me, and I'm glad they did. And I've been in charge of that for the last 2.5 years. I'm chairing this work group because the Healthcare Commission came to me and said, would you be willing to do this? And I said, of course, this is a vital issue and needs to be addressed. So we recruited all of you. Thank you for that. As you know, this was a requirement. This was a statutory requirement since it is legislation passed by the legislature this past session. And I know that we will hear more about this from the Healthcare Commission staff in terms of the process. Courtney will be talking to us about that in a moment. But I just want to say that it's been, it's always wonderful to work with the Healthcare Commission, especially on this. And this is this committee and this process that we are working on in a fairly fast pace for government things is to develop a public information campaign that we can take back to the department and back to the legislature to develop, to hopefully get funding. Obviously, that would be the goal, so that we can actually enact that campaign. But there is no funding right now, just so everybody knows that. That this is just one step in that process. We've had the commitment of several communications specialists who are on this committee or are willing to support us, including Maryland Public Television, which is vital to this process since, this entire committee is a bunch of smart people, but we need the people who actually know how to put together a public information campaign to help us develop that plan and bring it back. Finally, I will say that as you may know from the legislation, a report is supposed to be back to the legislature on November 1st. That's an incredibly short period of time for a group like this, especially one having to be organized through the Department of Health to act. We have asked for an extension. We hopefully and probably almost certainly will get one just for a month to give us a little more time, and especially, again, our communication experts to give a little more time to develop that plan and for us to meet to discuss it and approve it. So that's sort of the overview. Again, thank you all. And now I will actually turn this over briefly to, before we do introductions, I want to turn this over briefly to our vice chair, somebody else I've worked with for forever, Teresa Lee from the Maryland Healthcare Commission. Teresa, what did I miss and anything else you want to say?
Oh, okay. You actually didn't miss anything. I'm Teresa Lee. I'm the director for the Center for Quality Measurement and Reporting, and I'll put in a plug-in for our main product, which is a consumer website that provides information on the performance and quality of hospitals, nursing homes, assisted living facilities, health plans, a variety of provider types. So I encourage persons to take a look at it when you get a chance. And the URL is at the bottom of the emails that you get from Courtney Carta. So it's right there, and you please feel free to take a look at it. Let us know what you think. Always putting in a plug for that. But on the behalf of the Maryland Healthcare Commission, I would like to welcome everyone to this first meeting of the Workforce Violence Prevention Awareness Campaign Work Group. Ben Steffen, our executive director, has a scheduling conflict and hopes to join the call later, because this is a very important project for all of us. And we are definitely happy to partner with the Maryland Patient Safety Center to implement the requirements of this new legislation. We're also very fortunate to have Dr. Ige leading this effort as our chairperson. When this legislation passed and MHCC was given a key role in facilitating the work, the quality team immediately began the process of educating ourselves to prepare for these meetings. And we understand this is clearly a complex issue and more acute than I think any of us realized before getting involved with this. MHC staff, Courtney Carta and Sumitra McCammon, have worked hard to put together a concise presentation that highlights various workplace violence prevention campaign efforts to get us started today. But I want to make sure I clearly communicate that we recognize that you all are the experts, and we are here trying to facilitate a balanced and productive and inclusive process under the guidance of Dr. Ide. So having said that, I'll turn it over to Dr. Ide.
Well, thank you. Thank you, Teresa. And thank you everybody. We're going to go quickly through the group so you can introduce yourself and your position. You can quite welcome to make any comments, but we've got a full agenda today, so I don't want to take too long. And having now spent 2.5 years on Zoom, I know I will ask you by name to introduce yourselves so we don't have to guess when we are supposed to introduce ourselves. So we're just going to go on my squares here. Karen, you're first up.
Hi, I'm Karen Carloni. I'm with Southern Maryland Community Network. We're a nonprofit community behavioral health program in Southern Maryland. And I'm also representing the Community Behavioral Health Association of Maryland.
Thank you, Karen. Courtney, a vital member of this committee.
Hi, I'm Courtney Carta. I'm the Chief of Hospital Quality Initiatives here at MHCC, providing staff support to this work group. So really happy that we've gotten started and happy to be here today.
And now a person I met like over about 25 years ago, Lisa Tenney, when we were both very young.
Yes. Hi, I'm Lisa Tenney, and I have a background in psychiatric nursing and in emergency nursing, and currently work as a risk management patient safety coordinator. I am currently out in Denver at the National Emergency Nurses Association, and I have to tell you, the interest in what we are about to do as a group is of interest to the rest of the nation of emergency nurses. So thank you for including us.
Thanks, Lisa. And now the person we can all thank for getting this through the legislature, Pegeen Townsend.
Hi, Pegeen Townsend. I'm the Vice President for Government Affairs at Medstar Health. And I really recognize the severity of this problem, and it's increasing. So I'm very happy that all of you all have decided to help on this initiative.
Thanks. And Sharon Owens.
Hi, Sharon Owens. I'm the Director of Nursing for Surgery and Physical Medicine and Rehab at the Johns Hopkins Hospital, East Baltimore.
And Erin Dorian.
Hi, I'm Erin Dorian. I'm the Vice President of Policy at the Maryland Hospital Association.
And Donna Zankowski.
Hi, I'm an occupational health nurse, and I currently work for the American Nurses Association doing COVID education. And I'm also here representing the Maryland Nurses Association.
Thank you. And Candy McFarland.
Hi, everyone. Thank you for having me on this amazing work group. I currently serve as the Vice President for all of the behavioral health services at Adventist Healthcare.
Thank you. And Samantha McCammon.
Hello, everyone. I'm Sumitra McCammon, and I am also working with Teresa and Courtney, providing staff support to the work group.
Thank you, Sumitra. Sorry to mispronounce your name there. The names are small for somebody of my age. That's okay. And Amy Goodwin.
Hi, everyone. I'm Amy Goodwin. I'm the Vice President of Communication at Maryland Hospital Association. Happy to work with all of you.
Thanks. Matthew Levy.
Hi, good afternoon, everybody. My name is Matthew Levy. I'm an emergency physician and EMS medical director, and I'm here representing TraumaNet and the EMS community at large. So thank you.
Thanks. Christina Hughes.
Hi, everyone. Good evening. My name is Christina Hughes. I am the Vice President of Healthcare System Preparedness and Chief Preparedness Officer at Medstar Health. I am an emergency department nurse by background.
Thank you. And Stacy. You're
on mute, Stacy.
Hold on. Got it. Is that better?
Yeah.
Sorry about that. Good evening. So I am the chief clinical nurse for Autumn Lake, and I oversee 33 nursing facilities in Maryland.
Thank you.
You're welcome.
And Lorraine.
Hi, everyone. I'm Lorraine Arikod. I am the policy analyst for 1199 SCIU. We represent over 10,000 healthcare workers in hospitals, clinics, and long-term care facilities in Maryland and DC.
Thank you. Matt Hombach.
Matt Hombach, Executive Vice President at Nevins and Associates. Have worked with in a communications and marketing role with a variety of healthcare entities throughout Maryland for 2 decades. Longtime partnership with the Maryland Patient Safety Center, and honored to be a part of this group from that lens, but also as a husband of a healthcare worker.
Thank you. And Maggie?
Hi, I'm Maggie Beets. I'm from the Maryland Department of Health's Office of Communication. And there I primarily support the Behavioral Health Administration.
Thanks. And Mark?
Hi, everyone. Mark Marino. I am I'm in the newly created position of Director of System Workplace Violence Prevention Programs for Medstar Health. And I'm a nurse of 30 years and have been working in the workplace violence prevention arena for several years now.
Thanks. And James Gannon. James?
Hi, I'm James Gannon. I'm the trauma program manager for Sinai Hospital, but I'm here as the chairman of Maryland Trauma Center Network, TraumaNet.
And Anna Kerbel, who works with me. Anna?
Hi, everyone. I'm Anna Corbel. I'm the Director of Business Development and Marketing for the Patient Safety Center. I will be supporting Matt and Amy in the communications development part of this plan, but I also have a vested interest in the topic as I've been working with the Caring for the Caregiver Implementing RISE program with Johns Hopkins now for about 4 years. So we focus on peer support for distressing situations with healthcare workers. So I'm interested in continuing this conversation with you all. Thanks for being here.
Thanks. And also some more people from the Healthcare Commission. Tracy DeShields.
Hi, I'm Tracy DeShields. I'm with MHCC, and I'm just observing today.
She's important at MHCC more than just with, but that's okay. And Lavone, do you want to introduce yourself? Or are you on?
Lavon is our IT person, so he's
our IT person.
Yeah, he's a very important person.
Yep.
We're just glad he's around, that's all. So again, thank you all for attending. We have a few who were not unable to attend today, but we'll involve them as we go along and talk a little bit more about that. But without further ado, let's move this along to the next agenda item. And Courtney and Sumitra, I think, will be giving a little overview of this, the legislation and the committee that we're all involved with. So Courtney, take it away.
Sure. Can you see my presentation?
Yes.
Yeah. Okay, perfect. Okay. All right. So thank you again, everyone, for joining our meeting today. We're excited to get this started. I'm Courtney Carter. You probably recognize my name from the emails. So here I am. This is what I look like. Also, just want to thank my colleague again, Sumitra McCammon, for helping pull this information together for this presentation today. We want to set the stage a little bit today. We've done some background research for the past couple of months. We recognize again that we are not the experts. We are relying on your input. in these meetings, but we did gather some information on workplace violence in healthcare settings. We've also gathered some information to see what other states are doing and what other countries have kind of done in this space. And at the end of the presentation, I will actually have a couple of video clips to show you from real campaigns. Okay, so just a quick background. Hopefully everyone has had a chance to read the Senate bill. I sent it yesterday in the email, but it just outlines our charge to develop a public awareness campaign and create a plan for implementing the campaign. And it is due November 1st. Again, if maybe you joined a little bit late to the meeting, we have requested an extension, but for now we're working on that November 1st deadline. So it is fast moving. And I'm not going to read this slide, but it just outlines the need it says what we're required to do. We have to focus on the magnitude of incidents of workplace violence in healthcare settings, provide information about the consequences, and also urge the public to respect and protect healthcare providers from workplace violence. And we also have to recognize and accommodate the needs of patients with mental health disorders and substance abuse disorders. Okay, so I think most people on the call are familiar, but for those maybe the communications folks or others, OSHA does define workplace violence as any act or threat of physical violence, harassment, intimidation, or other threatening, disruptive behavior that occurs at the worksite. It ranges from threats and verbal abuse to physical assaults and even homicide. During my research, I found a lot of very alarming statistics. So that'll be my next slide. But also, according to OSHA, acts of violence is the third leading cause of fatal occupational injuries in the US. So when we look at workplace violence in healthcare settings in particular, again, statistics are pretty alarming. About 75% of workplace assaults occur in healthcare settings. Healthcare workers are 4 times more likely to be a victim of workplace violence and 4 times more likely to take time off due to work, due to violence or related injuries. Not all incidents are reported, so these numbers are probably rather low. And workplace violence does take a toll and have consequences physically, personally, emotionally, and or professionally. It can also result in burnout of healthcare professionals. So I'm not going to go through this slide in too much detail. There are 4 different types of workplace violence. This chart comes from the CDC website. I liked it because I thought it outlined each type pretty clearly. But type 1 involves criminal intent, though maybe not directly related to the business. So maybe something, a crime occurs in the parking lot. Type 2 involves a customer or client interaction. Type 3 involves violence between colleagues. And type 4 is when maybe there's a personal relationship involved that may spill over, like maybe the spouse might follow the employee to their place of work and make a threat. So for the purposes of this work group, I outlined type 2 because I think that is the most relevant. But again, when we get into the discussion later, definitely feel free to chime in if there are other types of workplace violence that you'd like to discuss. So in our environmental scan, we found some common factors that might lead to violence in healthcare settings in particular. Patients with mental health or behavioral health problems, also substance abuse patients. Just want to point out again that these are specific areas that the bill requires us, the work group, to address. We also found that violence from the aging population, particularly those with dementia, were more likely to exhibit violent or threatening behavior. Violent behavior also tends to occur more frequently in the emergency departments, particularly when there are long wait times. Staffing shortages came up a lot in our literature when there's less time to dedicate to each patient, or maybe they've been waiting for a while. It might lead to frustration and could result in abusive behavior. We also found that some facilities maybe didn't have regular training to be able to, for their staff to be able to recognize potentially violent patients. And some facilities have reported limited security. So again, just want to point out, this is probably not a comprehensive list, especially compared to what you all do and see professionally all the time. But these are just some of the common themes that we did come across. So we also wanted to look and see what was available nationally. And really what we found were some general resources, particularly from OSHA and the Joint Commission that established workplace violence policies and prevention. There were also some other national organizations that provided some toolkits and some checklists and some various resources. And actually the American Nurses Association has an actual campaign. I'm going to get to that in a couple of slides, so I'll come back to that. In terms of national legislation, there was a bill introduced in 2019 that would require hospitals to develop and implement a comprehensive plan for protecting healthcare workers from workplace violence, but unfortunately that did not pass. Okay, so we also looked at the Maryland landscape just to see what kind of efforts were happening statewide. And I'm actually not going to say too much about this because we have another presentation coming up afterwards that'll get more into the details. But I will say that in Maryland, assault on a healthcare worker is only a misdemeanor. It's not a felony. And most of the information I did find about Maryland came from the Maryland Hospital Association. They conducted a survey back in 2019 to assess workplace violence incidents and preventive practices. So I think Aaron will address that in the next presentation. Okay. So we looked at to see what other states were doing in terms of campaigns. We didn't find a lot of actual campaigns, but what we did find were some other activity or efforts to at least try to address workplace violence. We found a lot of states had toolkits. Some states were required to display signs. So you'll see here on the right, this blue square. This is actually a sign that Oklahoma hospitals have to display in their facilities. Other states had mandatory incident reporting. There's been legislation across some states. Some hospitals or some states are requiring staff training and education. So it's really kind of a mixed bag, but not a lot of public awareness campaigns in particular. I did find two hospital-specific initiatives that I wanted to share today. One is Piedmont Healthcare in Georgia. They created some simple signage and began conducting some bedside threat and risk assessments. And over 5 years, they saw almost a 40% reduction in reports of verbal and physical abuse of their employees. So the signs, they just say our workers have the right to be treated with dignity and respect at all times. They should be able to do their jobs without being physically or verbally abused. Thank you for respecting their right to an abuse-free workplace. So that's great that they've seen a lot of success with just posting signs. The next hospital-specific initiative I wanted to mention was the Cleveland Clinic. So this is not really a campaign, but they have taken an approach to training all of their hospital safety officers in de-escalation. And everyone as part of this program wears khakis and polos to appear more approachable instead of disciplinarian or maybe law enforcement. So even though it's not quite a campaign, I did think it was an interesting approach because they were kind of focused on tone and appearance. Okay, so a couple slides ago, I mentioned the American Nurses Association. They do have an excellent webpage dedicated to stopping nurse abuse. So they've created this hashtag called End Nurse Abuse. They have a plethora of materials. They've got printed materials, a webinar, videos, radio ads, a letter to lawmakers. You can sign up for their online pledge supports. So really a lot of great information. So they have two things I want to share with you today. So the first is an Iheart Radio ad. So that's Sirius XM ad, I think. And then, so that's short. So I'm going to play that now. Let me turn my volume up a little.
1 in 4 nurses experience workplace violence, such as physical violence, disruptive behavior, intimidation, or harassment from patients, patient's family, or hospital personnel. This epidemic has devastating results on the healthcare industry and needs to stop.
As someone who's witnessed violence against nurses firsthand, I firmly believe that we can and must do more to stop nurse abuse. If your nurse is facing violence in the workplace, then they can't care for their patients or do their job properly. While nurse abuse is far too common, it's also underreported. So if you witness an assault, it's imperative that you take action to report it and show zero tolerance. Every patient deserves to be cared for by nurses who are free from fear of workplace violence. Please join me in working to end nurse abuse today.
Join the movement to stop workplace violence. Learn more at endnurseabuse.org, brought to you by the American Nurses Association.
Okay, so that was the radio ad, and now I want to play an animated video for you.
The following is a reenactment of a true story of workplace violence. Due to the sensitive nature of the material, viewer discretion is advised.
I was assessing an IV site when the patient violently grabbed me by the hair and jerked me towards him, trying to bite my face. Thankfully, there was a coworker in the room with me at the time who was able to call for help. I completed an employee injury report and was told by the nursing supervisor that there was nothing that could be done. And they didn't let me go to the ER to be evaluated because we were short-staffed. I now suffer from chronic neck and back pain.
Silence no more. Violence is not part of the job. You can help end nurse abuse. Visit endnurseabuse.org to take action.
Okay, so 2 different mediums, but both I think pretty powerful. And we also actually looked at some international campaigns as well. Interestingly enough, seems to be a lot of activity about workplace violence in Canada, particularly among the nursing unions. So the Nova Scotia Nursing Union has created some TV and print ads. You'll see the brochure I included on the right. And I actually have a couple of videos that I want to play from them too. They're short. So this is actually their website. You can see they have a tab here for advocacy and campaigns, and you can download some of their materials. But they also have a couple of YouTube videos.
On a daily basis, verbal abuse, threats, harassment, and physical assaults are a common occurrence. It's disturbing and unacceptable. Nurses endure one of the highest rates of workplace violence.
I didn't know he was there.
Violence, it's not part of the job.
Okay, so that was the first one, and here is the second one.
Home, it's where we usually feel safe, but not always for those who provide care. It's disturbing and unacceptable. Nurses endure one of the highest rates of workplace violence. Violence, it's not part of the job.
All right. So, and then Australia actually has a government safety program called We Work, and they've also created some TV ads for both hospital and nursing homes. So I have just 2 more videos, and these are short as well.
I'm here to help when you need it most. Coordinating your care, listening to and supporting you and your loved ones through your recovery. And this is how you treat me.
Up to 95% of our healthcare workers have experienced verbal or physical assault. No matter what the situation, it's never okay.
Right, and then this next one is geared towards nursing homes.
I work in aged care to give elderly people the care, emotional support, and companionship they need. I care for your loved ones, your mothers, fathers, husbands, wives, and grandparents. This is how you treat them.
Up to 95% of our healthcare workers have experienced verbal or physical assault. No matter what the situation, it's never okay.
Okay, so I promise that's all the videos I have for you, but I just think it's interesting to see kind of the differences and the approaches that each different group has taken. Some are a little bit more dramatic and graphic, and others, you know, with the animated video, a little softer. So hopefully those were interesting for you. So just kind of want to wrap it up. So overall, a couple of themes that we found, again, actual workplace violence public awareness campaigns are limited. And when we did find them, they were mostly sponsored by nursing unions. Most of the existing material that we found were toolkits really to help hospitals with prevention, but information was really limited for other types of healthcare settings. I know I showed you a nursing home specific video, but that was all the way in Australia. That's pretty far away. And lastly, some of the interventions and activities we found tended to emphasize what facilities and providers should do in terms of training or education, but there was limited accountability from patients or family members. And just to, again, summarize some of the information we gathered about campaign messaging, what we've read is that multi-pronged approaches are best, reaching multiple media channels. You saw the American Nursing Association, they had an array of different materials available, and that really does help to reach multiple types of audiences. And it's also important to ensure that the campaigns and the messaging isn't too negative. You don't want to deter potential recruits, or you want to keep the employees that you do have, and you don't want to scare away potential patients either if anyone thinks it's an unsafe environment. So I believe, yep, that is my last slide. So if anyone has any questions, I'm happy to answer those. I know we have a packed agenda though, so we could also move on to the next presentation. Dr. Ide, I think you're on mute.
You are absolutely right. Can you stop sharing so we can see everybody?
I sure can.
And thank you. That was wonderfully comprehensive and a good overview of what's going on, and it helps us with sort of the multiple directions we can go in, and we'll have that discussion. But any questions for Courtney about her research and what she's found? Again, quite useful. And one other question for me, Courtney and Teresa, can we share this presentation, any of these presentations with our committee?
Yeah, so the plan, sorry, Teresa. So the plan is to send all the materials out afterwards. We're going to summarize the meeting too, especially for those who couldn't make it. And we're going to put this information on the MHCC website, and we're recording the meeting. So you should have everything available at your disposal.
Thank you.
And I'll just jump in. Courtney, there are a couple of state hospital associations that have run PSAs or created posters, not a full campaign, just some individual pieces. And I can share those links with you if you'd like to add them.
Yeah, sure. That would be great.
Thanks, Amy. Anyone else? Then we can go ahead and thanks again, Courtney. And Sumitra, that was a great introduction. Now we can see, we can go on to presentations by the Nurses Association and the Hospital Association, and what they've done, what they want to do, how they want to help us. I think in order, we're starting with the Maryland Nurses Association and Donna.
Yes, thank you. I'm going to try and share my screen. Let's see. And okay. And can you see it okay?
Yes, yes.
Okay. So, I didn't get a chance to coordinate anything with Courtney. So I have some repetitive stuff that Courtney already hit on, but that's okay because I plan to move through this really quickly. So, okay, so we did talk a little bit about the official definition of violence. And for me, it's really important to think about the many ways that violence materializes, because how do we explain this to the public, because sometimes they don't really understand that it extends all the way from physical violence to bullying and harassment and threats. So thinking about, the definition helps me kind of get a better idea of the message. There are the 4 basic types, and Courtney's right, most type 1 is that criminal intent, the type 2, the customer on client, on healthcare worker. This is the type that's mostly trained on in healthcare facilities. Like when you buy a workplace violence training program for your employees, they mostly focus on this type of violence. However, the others do occur too. Worker on worker often looks like bullying. And this is kind of can be really silent, because oftentimes this type of violence is really just reported maybe through our human resources channel. And so maybe, security is not necessarily aware that this is happening. Courtney mentioned personal relationship. There's one other type I just wanted to bring up. It's ideological violence or violent extremism. And we have seen that recently around, like, for instance, if someone has a political or a religious or social purpose for violence. So it might be threatening at a Planned Parenthood clinic or a facility that provides abortion care. We've seen disruptions at vaccination events around COVID-19. So just to be thinking about that type of violence as well, or violence with a purpose. And Courtney did talk about the effects already. But, it's not just the fact that the worker is injured or the patient or their family might become injured. We know it creates a tremendous amount of dissatisfaction among staff, but we actually have data that it negatively affects patient care. So not only the patient that's part of that workplace violence event, but the next patient as well, because if you have an injured nurse or healthcare worker, it's really difficult for them to go on to the next person and deliver really high quality care because they're traumatized. And so it has sort of a domino effect throughout the entire facility, even if that particular patient isn't involved in the event. So to think about the effects for the whole system. And, we've heard anecdotal stories about how difficult it's been during the pandemic, right? And how it actually got worse. As bad as it was, it actually got worse. So the American Nurses Foundation looked at that, and they surveyed almost 12,000 nurses. And this survey just closed this past July. And basically what they found is that, in addition to nurses feeling like they haven't been heard, ongoing horrible staffing issues, unhealthy work environment, they were specifically asked about workplace violence. So the first question was, have you experienced, bullying or incivility in the last year? So that 12 months, from July to July, 60% said that they had. And when they asked specifically about physical violence at work, 29% reported that they had been assaulted in the last year. So that's terrible. But it's as bad as we thought. Courtney mentioned OSHA and Joint Commission. And so, there isn't really a workplace violence standard through OSHA right now. And that if OSHA does inspect in a workplace violent event, the only thing they use is the general duty clause, which is very difficult to actually use for workplace violence for many, many reasons. But they did propose creating their own workplace violence rule. And it's still in the process. They officially started in 2016. Currently, it's still in a small business review stage. And they're talking that maybe that will be completed this coming winter. So I hope that's true, in which case there'll be actual workplace violence standards. Courtney mentioned this federal legislation. Actually, so this bill was reintroduced in this current Congress. In the House, it passed. And then it was introduced in the Senate side this past year in 2022. And right now it's sitting in the Health Committee of the Senate. And I don't even know that it will be voted on at all this year. But, you know, if this legislation were to pass both houses, basically all it would do would be make OSHA hurry up and finish their workplace violence standards. So it doesn't create anything really new. It just makes OSHA kind of get on with it. And of course, in the absence of actual regulations from OSHA, they have guidelines, which are the basic thing that most workplace violence prevention programs are based on. So, and you'll have all, you know, for anybody that's interested, you'll have all these links in the presentation. So, and then of course, OSHA has all these recommendations, which are really contained in workplace violence legislation and programs, you know, generally. The Joint Commission did a really interesting thing. So this past January, they actually enacted workplace violence specific standards. And I was fortunate enough to be on the review panel for these standards. So I kind of had some time to, you know, ruminate over them. And on paper, they are wonderful. I have no idea in practice if they're effective or not. It just went into effect in January. You know, the thing about Joint Commission inspections is unless you're part of it, you don't really get any information about how it went or what they found or, you know, any data or details. So I don't know, you know, I've asked people on the ground when their surveyor came through, did they actually ask about your workplace violence events? Did they want to, you know, talk to an employee about, you know, their training on workplace violence? And so far, no one has had any interaction regarding these new standards. That doesn't mean it's not happening. It's just I haven't heard a single thing. So if any of you know of any of that, please let me know, because you know, I would really like to know going forward so I can get back to these folks to try and get a bit more information. So there are, as Courtney mentioned, workplace violence laws across the country. They're all a little bit different. Yeah, in Maryland's here, you know, we have a workplace violence law that we passed back in 2014. We expanded it to cover nursing homes as well. So it's acute care settings and nursing homes. And on paper, it looks wonderful. You know, it has everything that you want in a workplace violence prevention program. But the thing about our law is that it has no regulatory component to it. So there's no enforcement piece, and there's no agency that oversees it, right? And there's no data collection piece, right? So we really, even though facilities are asked to report and track, that information is not really shared. So, you know, a friend of mine that does advocacy said, you know, laws like this, which are meant to be very good, but without an enforcement piece, are more like legislative suggestions. So, you know, I don't know. Now, some facilities in Maryland have done a very good job embracing this, and they're living it. And I think Pegina is probably going to talk about her facility, which has done that. But I got to tell you, on the ground, other facilities have not. And so we have a long way to go to, you know, even though we have a wonderful workplace violence law, you know, maybe it's not as effective as we really hoped. And so how can we really get there, right? How do we advocate for a safer workplace? My personal opinion, and also the opinion of the American Hospital Association, is that healthcare worker safety has to be an equal importance to patient safety. They're the same. We have to go beyond just thinking about, you know, patient safety and look at a culture of safety for everybody. If that means integrating safety systems, integrating the way we collect and share data, safety dashboards, however we can make sure that staff is just as protected as patients, and that high priority is placed on their safety, I think that's when we're going to really make a dent in workplace violence. And so, as Courtney already presented, it's definitely not part of the job. And, we have a long way to go with our own staff to train them that it's not part of the job, because unfortunately, they've experienced so much workplace violence now that they've come to accept that it is part of the job. And so we have work to do even among healthcare workers. And again, if we can get that data, just like we would for any patient safety issue, I think it would go a long way. It is extremely underreported, so finding a way to enhance reporting. But, and I think that's why we're here. It's that squeaky wheel phenomena. Things aren't going to improve until the full scope of the problem is out in the open. And I think having things like this panel and doing a public awareness campaign is a way to help accomplish that. So thank you. I apologize that a lot of it was repetitive.
No, it was great. Thank you. It's great.
I'm not good at this mute thing, I guess. Thank you, Donna. That was excellent. And I agree completely with your last statement there. We've got a very specific agenda and goal, very short time period for this specific work group. It's a public information, public awareness campaign. But you're right, it's one step towards it and one squeaky wheel towards it. So greatly appreciate that. And thank you for the presentation. Any questions for Donna? Hearing none, we can move over to the Maryland Hospital Association and Erin Dorian.
Thank you, Dr. Ig, and hello, everyone. I am going to share my screen. Okay, what are you seeing now? My PowerPoint? Yeah, okay.
Yes, we do, yes.
Perfect. You just get it into, you would think I should know how to do this by now. Okay, you're still seeing the PowerPoint?
Yep.
Okay, great. So I'm just going to talk a little bit about the work that the Maryland Hospital Association has done over the past few years on workplace violence prevention and some new recommendations that are coming out of our workforce task force. So just as a little bit of a timeline and how we started on this, we only went back to 2018, about four years ago, 5 years ago, depending on, we're almost into 2023 now. So about 5 years ago, we held our Safe Harbors Workplace Violence Summit. And from that summit, we created our joint MHA-MNA steering committee. So that steering committee met from 2018, until 2020, taking a little pause during the COVID pandemic. We thought it would be a little bit shorter than it has been, but the pandemic has been a little bit longer than I think everybody thought it was going to be. So then in 2019, we released our hospital survey. Our steering committee helped guide that survey. We also released an online resource guide. And we started our legislative work in 2019. So it took us a couple of years to get some of the wins that I'm going to talk about now, but we did advocate for things every single year in the legislature. So by 2020, we were able to get a piece of legislation passed that would have, allowed facilities to decide how name tags how names on name tags had to be displayed. Prior to this, the OHCQ took the opinion that name tags needed to have first and last names on them. And then what we were hearing from some staff was that, they were getting threats because, patients' families and others could find them by their name and last name. So this legislation allowed for a bit of flexibility in that. And then in 2021, we were able to pass House Bill 289, which allowed for a facility to petition for a peace order against an individual on the behalf of their staff or on the behalf of a staff member in their facility. So this would allow for the peace order to sort of extend into the hospital facility. So this slide just shows some of the pieces of collateral we were able to develop. We did an issue brief. I believe this was 2019, but Amy might correct me. At our summit, we had an expert come in and do a very interesting presentation. On the upper right-hand side, you can see this is still on our website, the resources that we have available, and then just the bills that we were able to pass. Onto that survey that you heard Courtney talk about, we did survey our members, and we found some interesting but not surprising information. The highest risk patient care areas tend to be the EDs, behavioral health units, and labor and delivery. That was a little bit surprising to us, but I don't think surprising to the nurses on this call. We also asked our hospitals whether they've had to invest in additional in their security budget in the past 5 years, and 91% of them said yes, and they did everything from cameras, additional security coverage, personal panic buttons, all of these kinds of things. And then you heard from both Courtney and Donna some of the challenges in identifying the number of incidents, and the number one challenge was underreporting by staff. There's also no, even though we do go through the definitions of workplace violence, some people, it's not very clear when to actually report. There's no centralized data collection. And by that, I mean, the state isn't collecting data. OSHA's reportable events only cover, a small sliver of the events that actually happen. And they only report events that result in days away from work. And so we don't have sort of industry level definitions of what to report beyond what OSHA requires. So I just want to talk very, very briefly about the 2022 State of Maryland's Healthcare Workforce Report. We released this in August of 2022. This came out of a 9-month effort from our task force on the Maryland's future healthcare workforce. We pulled this group together at the request of our executive committee, understanding that the workforce was in crisis. We had 1 in every 4 hospital and nursing positions were vacant. And there was a growing shortfall of nurses. So this task force was brought together to talk about the whole workforce, and they decided in the first 6 months to focus on the nursing workforce. And it wasn't just workplace violence, this was looking at the workforce. And so the task force developed 3 high-level pain points. So that is high staff turnover, shifting care delivery models, and insufficient pipeline. From there, they broke down recommendations for each of the key actors, high-level recommendations that I will get into in a second, but our recommendations included expanding the Maryland's workforce pipeline, removing barriers to healthcare education, retaining the healthcare workforce, and leveraging talent with new care models. So where we really found workplace violence to be the biggest contributor was on that high staff turnover and a key barrier to retaining the healthcare workforce. So again, the challenge, high staff turnover, and the majority of workplace violence incidents impact nurses and nursing assistants. So, I don't know what just happened. I went too far. Okay, so on our recommendations to address challenge number 3, challenge number 1, recommendation number 3 was to retain the healthcare workforce. In our rationale, you can see some data here. In 2020, nursing and personal care facility workers were injured at a very high rate, 5 times as likely to be injured on the job than the workforce overall. And so the recommendation from our work group for policymakers was to establish a statewide workplace violence prevention consortium to provide training and support and recommendations for policy changes. So we believe that while we're very excited for this public awareness campaign work, that this will also help us continue to move that ball forward and have policymakers really pay attention to this issue. So with that, I will pause and answer any questions.
Thank you, Erin. Any questions?
And Don, I see that you corrected our BLS report in my definition in there. So that's great, but thank you for that.
Thank you, Donna. Any other questions for Erin? Okay. Thank you, Erin and Donna, giving us those updates. Obviously, understanding essentially what's going on and what is being done. Now to get a little further into what one system has done, and a lot of work, it seems, I'll turn it over to the representatives from Medstar, and I think, Pegeen, you'll get us started at least.
I will. Thank you very much. I have with me that also serve on this committee 2 of our experts in this. I'm just the chief groveler. So I'm very happy that the people that actually know what we're doing and are implementing what we're doing. But I would like to say that I think this issue is not unique to Maryland. It's not unique to Medstar. It's across the country, and hospitals have taken it very seriously. So I don't want you to think that only Medstar is doing anything in this arena, because I'm going to say all hospitals are doing something, because you actually need to retain your staff, as Erin just said. So let me turn it over to Christina Hughes, who's our Vice President for Health System Preparedness, and Mark Marino, who's our newly created Director of Medstar Health Workplace Violence Prevention Programs. So Mark and Christina.
Do you want Courtney to advance the slides for you?
I'm happy to share screen, or if you want to put yours up, it makes no difference.
Which would you prefer? We can do it either way.
I'll share screen, thanks.
Okay.
Okay, well, thank you, everybody. Again, Mark Marino, and I'm in the new position of the Director for Workplace Violence Prevention Programs. And I say that with a lot of trepidation. I am pained to think that healthcare has come to the point where systems now potentially need directors for workplace violence prevention programs. So I'm grateful to be part of this committee in hopes that it can make a difference, but it's still a sad day to me nonetheless. Just briefly share a little bit of data with us and then some initiatives, and Christina and I are going to share presentation responsibilities. We are collecting data in this realm. Obviously, we look at our health data, what gets reported to OSHA, and then we use RL Solutions. It's a patient safety database. We use it to capture also our workplace violence episodes. So our staff enter episodes in there. We do have issues with that in that it is meant to be a patient safety event reporting system. So when a staff member is assaulted by a patient, the staff are a little hesitant because they view it as a system for patients. This is how we're breaking out our workplace violence episodes as we review these in our patient safety event reporting system. So right now, about 10 of them, and I'll share a little bit more with you from a pie graph standpoint. Then we also look at what are some of the contributing factors, whether it be medical delirium, whether it be drugs, other precipitating factors to violence. In our hospital, so this is looking at this fiscal year, you can see where a lot of our violence is occurring. It's ED, and when you add in the psych-specific emergency department areas, it becomes almost half of all of our workplace violence episodes. You throw in behavioral health, and that you can see it's pretty significant. And the general inpatient areas also are significant places for workplace violence. This is how we are breaking out our violence. You can see it's broken out by physical assault, everything from physical assault to stalking and sexual assault, even patient on patient. So we do get reports of patient on patient assault, and we've had patient on family, family on family. You pick it. We seem to experience all kinds of violence in our hospitals, and I'm sure that's not unique to Medstar. Some other contributing factors, medical delirium. We've had patients come in high on PCP and have caused significant damage. We've had patients commit significant property damage as well. I think what's really telling is we've done some reviews, medical record reviews on the patients who are coming in and committing active violence. This is on the ones where we're able to identify patients associated with the violence. You can see a significant portion of them have histories of behavioral health or mental health issues. And I think that's important to note in that if we know upfront and beforehand the groups of patients that are potentially at risk, can we change our approach to help mitigate potentially escalation and future physical violence? Some of our initiatives. So we have a system workplace violence prevention committee, and that system is the system committee is represented by members of all of our hospitals, as well as diversified businesses and corporate representation. We use that committee to review reports, events, and trends. I put all that together and share it at the committee level. We also try to do information and literature sharing. So we'll pull a journal article or look at best practices. The group has also come up with some really good ideas and recommendations for infrastructure and IT solutions to mitigate violence. And we've done some really pretty neat things that have been originated by this group. And then we're working with the system safety team to improve how we report and capture the data. And then the entity, the hospital-specific workplace violence committees, they're kind of the fingers for the corporate work as well. So they'll help disseminate information. They'll review their hospital-specific violent events and try to look at what were precipitating factors and if there was anything preventable. They collect frontline feedback for the system committee, and that helps guide initiatives and directions. And additionally, we've got a pretty comprehensive training program, and they facilitate some of that training down at the local level, whether it be on the units or facilitating classrooms and whatnot. And then they provide entity awareness of system initiatives. So they'll share some of the big things that are coming down at the system level. Christina, your turn.
Great, thank you so much, Mark. So you heard us mention a couple of times now that we do now have a full-time dedicated director in Mark for our workplace violence prevention programs across the healthcare system. So obviously we've seen as we've gone through this process in our committee work for many years that with the increase in frequency in events, and certainly all of these different initiatives that we have implemented and are ongoing, that we really needed a dedicated person to be facilitating those on an ongoing basis. So as you've already heard, specifically really delving into our data analysis, looking specifically at event reviews for the events that are reported and ones that come to our attention specifically, so that we can, learn things from them and make improvements as we go along for sure. Obviously, our training program, which we'll talk about soon here, is a pretty intensive effort in terms of organization, scheduling, really looking at the evaluations and feedback and making additional changes to the program from what our staff is telling us that's being helpful to them and things that we need to focus more so on. Next slide, please. So our electronic medical record, and I'm sure that many other hospitals and healthcare systems use similar tools, but certainly what we've found helpful is looking specifically at an assessment of risk and these types of behaviors, and actually a banner bar alert that would coincide with those identified behaviors relative to that patient. Certainly the important piece here is a continual review of that identification to see, are those issues resolving or are they persisting? And I'll talk a little bit about some other visual tools that we utilize that kind of go hand in hand with some of these things that we're able to do in our EMR. In addition to that banner bar, certainly also looking at specific care plans and interventions that are available to us to activate that sort of coincide with obviously the care that's being provided to those patients. Next slide. With regard to signage, we have implemented a purple safety flag that you'll see in a moment, which is a nondescript sign, but it means something to our associates. And so it does alert them, and this is particularly important for our support areas that are not within the medical record. So as we all know, environmental services, dietary, lab, radiology, and others that may be coming into a patient's room with really little to no background about that individual. And certainly if we know that there's a potential for harm in some way, we want to make sure that they are not going into the room alone. We also have employed across our healthcare system in a uniform fashion campus entry signs. This goes at our hospital entrances, in addition to our diversified businesses and even just business offices that house our associates. So you'll see that in a minute as well. And then of course, no weapon signage on our public entry doors. Next slide. This is that purple safety flag. And so what it tells our folks is that you should not be going into that particular patient room without two staff members for safety. And so this is something that can be implemented, is assessed on a continual basis for that patient's stay, but certainly has been, I would say, a tool to help our associates to feel safer. And certainly, as I mentioned, for those support areas that may not be within the medical record, specifically, really, really essential. Next slide. These are our signs that are posted at entry points to our facilities. These were thoughtfully crafted, and certainly we wanted them to address all different types of violence. So we expect this behavior out of our patients that are coming, visitors, as well as our associates. And so that's reflected here. We also thought it pretty important to actually work through our PFACs, our patient and family advisory committees, to look at the signage and the wording and ensure that it was something that our patients and our families felt was appropriate as well. And so we did make mention of that on the bottom of the signage here that is present. I would say also, obviously, this piece about pictures and videoing, that's of significant concern to our teams who, again, in many cases feel very threatened, sometimes terrorized by the things that our patients and visitors are perhaps are doing when they're in our presence. And so we felt it important to mention that specific piece as well. Next slide. We did engage a vendor, Masada Healthcare, that we have worked with for many years. And so we have been really heavily focused upon training for a very long time. I would say, throughout COVID and now to present time, we're really putting increased emphasis on that. Again, we have trained thousands specifically, and actually all of our associates specifically through a computer-based training that focuses on verbal de-escalation and a mnemonic therein to assist them in their ability to verbally de-escalate. We do, however, know, of course, that in some cases we do need to give our associates the physical and skills to keep themselves safe physically. And so we do go into those methods as well. As you've heard through some of these presentations, obviously we include home health and our urgent cares and our ambulatory sites as well. They're seeing lots of violence, and outside of the hospital, security presence is certainly limited. So they really need some additional support and assistance. We've looked at carjacking. We've unfortunately had associates who have experienced that in our home healthcare arena and such. And so we've kind of looked at all aspects and trying to provide them good situational awareness and training for all these different things that certainly could come their way. Within our in-person 4 and 8 hour classes, we do target different areas. So in high risk, you've heard ED, behavioral health, and security. At some of our facilities, that could also include other departments that seem to see higher incidents of violence. And certainly many other areas that you've heard talked about are general inpatient areas, as well as in some cases, our women's labor and delivery type areas that we see lots of violence as well. So certainly focused foundationally on verbal de-escalation, but including some physical self-defense skills, as well as safe restraint, take to the ground skills safely, as well as holds. We do, of course, offer paid time for our associates embarking on this training and continuing education credits for licensure for those that are taking the training. Next slide. Mark talked a bit about our data and our reporting, and we recognize that this is a challenge. And so we've been really trying to get quite specific about the way in which we analyze our data, trending it very specifically in locations and categories and associated pieces of this puzzle that occur with some of these incidents. And the other thing that we're really intently focused on, Mark mentioned that reporting, is actually developing a very specific workplace violence tile that will be utilized going forward that really allows for not just a patient safety event system, but for our associates who are the receiver of violence to very specifically delineate that when they're performing their very streamlined, efficient, with their time report, because we want to make this easy for our teams to be able to report so that we have an accurate picture to inform our strategies moving forward. Next slide. With regard to infrastructure and other support that we provide, clearly with regard to peace and protective and stalking orders, we do service associates in Virginia, the District of Columbia, and Maryland. So there are nuances and differences in the way in which these need to be obtained and what they are called. So we are in the process and have some guidance documents and checklists to make this easy for our staff in terms of how can you engage and the support that we do provide to help you to get these for your protection. With regard to handling of weapons and drugs, we're seeing this with increased frequency and are trying to enhance our protocols to provide our staff guidance on how to appropriately handle those situations that they are presented with actually quite often. With regard to those outpatient areas that I mentioned that do not have heavy security presence, we're looking very specifically at access controls and environmental things that we can do to enhance their workplace specifically, and talked about those checklist type things that we can assist our associates in terms of engaging law enforcement, our internal processes with legal and risk, and the support that we will provide to them. Next slide. So continuing on with that, obviously our care for the caregiver programs and also offering legal support if that's needed. If there are appearances or things that need to be taken care of, we are providing paid time for that so that that is not a stressor and an added stress to our associates who are experiencing this. Safety contracts for patients have been quite effective for us. And so making it known very clearly what our expectations are and what we will not tolerate while they are within our facility. And certainly if necessary, barring of visitors or discharging from care if that is absolutely necessary. As Mark mentioned, as nurses and clinicians at heart, and for our teams as well, that is a painful thing to have to think about, but it is our reality. And so we are supportive of our teams in doing those things. We have provided personal alarms for their safety when certainly entering, exiting our buildings, or just within our care areas, even if they need to utilize those to make a very loud, audible sound so that people are aware that something is going wrong. A little bit of talk already about badging, but that is a strategy that we employ with regard to first name only in many of our areas. And then trained violence interrupters. Pegeen may want to make an additional comment on that piece, but that is something that has been employed in some of our facilities that has proven to be beneficial.
Sure. This is really the Safe Streets program, where they train pretty much ex-offenders into being violence interrupters in their own communities. But we've had occasion, we have a Safe Streets program in South Baltimore where Harbor Hospital is located. And we now actually have a violence interrupter in the emergency department because of the retribution aspects that come with some of the gangs, and having somebody come in looking to finish the job, et cetera. And so we've employed this as another tactic.
Thank you, Pegeen. Thank you, Mark. So we're happy, of course, to take any questions. And I just want to say, as Pegeen mentioned at the onset, that we're really excited to be a part of this committee. Not excited that we have to all be here together, of course, but are thrilled to be participating. And we recognize that this is just our approach. We know from our colleagues, across the state of Maryland specifically, that we are interacting with, that places are doing lots of great work and good things in this space. And so we appreciate that for sure, and appreciate being given the opportunity to share our experience.
Well, thank you, Christina and Mark and Pegeen, for a very comprehensive review. And it's really, I think, extremely helpful to know what is going on in terms of the actions being taken. Again, we have a small piece of all of this, although a very, very important one in terms of the public awareness campaign. But I think it's going to be very useful for communications experts as they help us develop a plan for that awareness campaign, to be able to bounce ideas off of you and see what has worked and what hasn't worked in terms of the messaging that you've been using in your program at Medstar. You may have some experiences that will help us craft that, and I think that'll be very helpful. Any questions for the Medstar folks?
Donna has a question.
Yeah, I have one. Thank you. So, Christina, I have a question in terms of, have you been able to try and quantify any reduction in workplace violence after doing some of these, new initiatives like the purple flag or the signage? Because it seems to make sense that it would be effective, but do we have any actual data or proof that it is effective?
Well, I'll let Mark cover a little bit. So we do have a lot of good data with regard to our training effectiveness, and I'll let Mark touch on that. But to your point, Donna, I think one of the challenges that we're trying to really quantify is that anecdotally, yes, we do think these things are making an absolute difference. The problem is, with regard to looking at sheer numbers, we recognize the significance of the underreporting, and so it becomes a little bit hard to ensure that the comparisons we're making in terms of effectiveness versus quantity are real and accurate. But I will tell you from our sites and from the system committee that's been in place for many, many years, I've been chairing it for several of those years, that we are hearing that these things are absolutely making a difference for our team, but we are also hearing that the incidents, and particularly as things are opening up a bit more in the COVID environment with visitors and that sort of thing, we're definitely seeing increases in incidents. Mark, do you have anything else you want to add?
It's a challenge with underreporting, number one. And then the second part is, if it's already being underreported, we know that the incidence is increasing, but we're still getting underreporting. The challenge becomes, how do you know, short of anecdotally, when people say they do feel safer or they've got the tools in place? And in context of our emergency departments, if somebody's coming in and they're violent, the safety sign isn't going to mean a thing for something like that. So it's a challenge to measure, and I struggle, and I welcome ideas and thoughts on how we could quantify that to test its efficacy.
Yeah, and it is a tremendous challenge, and actually, the better job you do at encouraging reporting, the worse your numbers will look.
Yes.
And then you have to balance that against the effectiveness of your interventions, because you might be actually having way less violence, but because your reporting is better, it actually looks worse on paper. So it's a big challenge. But in nursing and in healthcare, we need data. We need to be able to show that something is effective, because we're a data-driven science. Thank you.
You're welcome.
Donna, I'm sorry, this is Amy Goodwin.
Go
What
ahead.
Mark and Christina mentioned is true nationally also, that we hear from other associations around the state, which is that after that initial phase of education, the escalation processes are put in place, the different initiatives are put together, you start to see more reporting of it. So actually it is really tricky and no one has figured that out as of yet.
Well, as from the Maryland Patient Safety Center and representing patient safety centers across the country, we always encourage more reporting, even if sometimes the data looks worse because there's more reporting. We need to know. We need that data. And so a public awareness campaign of this type, if that increases reporting, that will be a positive outcome of this campaign. It might define more work for us to do, okay, but we need to know. So thanks. I really appreciate that. Any other questions?
Yeah, I just had a question in a similar vein of understanding if the de-escalation trainings that are being provided, if there's data on like how effective that is. And also, I know 1199 has, I'm glad you mentioned that there's the purple signs for environmental services since we represent a lot of those workers, but I wonder if the training is also offered for environmental services and cleaning service aides in the hospitals.
So what we're doing right now, first off, we have a computer-based training for verbal de-escalation that got rolled out to everyone, from the president of the system, down to EVS and techs, the whole 9 yards. Everybody got that particular training. So that was number one. Number two, so it's recommended that your training be tiered based on risk. So for example, our EVS folks that might be assigned to a behavioral health unit, they should get the same training that the folks in the behavioral health area are getting as well. So we're tiering the training based on the risk level. Regarding the outcomes, we've actually have a data scientist who looked at before and after surveys for some of the training that we've been doing. And the data scientist at Medstar said he's not seen results like he's seen in this particular intervention for the very positive. So people do a survey pre and a survey post education, and they rate their comfort in dealing with escalating patients. And traditionally we've seen, really, really low. That needle got moved significantly up after the training, astoundingly so. So we are scientifically looking at least the training, the pre and the post, and people's comfort level at dealing with patients and family members who are escalating.
Any other questions?
Thank you.
Okay. Again, thank you all. These are excellent, have been excellent presentations. And again, we will distribute all of these to everyone so you've got the background. The remainder of this meeting is to get some feedback and to help our, again, communication folks. And generally, I'm referring to Matt and Amy and Maggie and Anna, who will be the folks who will help us develop this plan, because they're the experts. But we've got to provide feedback, parameters, concepts, ideas. There, as we've seen already, there are plans out there, but we need to tailor ours to Maryland and what we think is most appropriate for protecting healthcare workers in Maryland. Let me start off with asking any of the members of the committee who are attending today, if you have your own personal experience or that of close colleagues that you've witnessed with workplace violence. Those are usually pretty powerful. I don't know if anyone here has, but if you feel comfortable enough to talk about it, even briefly, I appreciate it.
So, as a nurse, I know it, but as a leader in workplace violence prevention at our facilities, I spoke with a nurse personally, a young nurse who recently graduated from nursing school, and she was in a patient's room hanging his IV antibiotics. So she was fiddling with his IV on his wrist, and this is in the middle of the night, the room is dark, she tries to keep it quiet. As she is trying to hook up his IV, he grabs her hand and places it on her genitals, his genitals, excuse me. Sexual assault, that is workplace violence. After that particular week, she left the hospital and she didn't go back to inpatient care. We had another instance, and I talked to one of the staff members with this patient who was high on PCP, and the nurse went into the room, a new nurse with not a lot of experience as well, and she mistakenly went around the bed to another side of the room where she didn't have good egress. He got out of bed and cornered her and had her in a chokehold. And if it weren't for a colleague who had walked past, hearing her, there's no telling what that outcome would have been. But these are the things that we're witnessing on a pretty regular basis.
Thank you, Mark.
Mhm.
Lisa.
As part of the Emergency Nurses Association, we have been testifying before the House and the Senate Judiciary Committees trying to get a felony workplace violence bill passed in Maryland. And a few years ago, we collected many stories, over 100, from ER nurses that they wanted the legislators to know about. And they were cleansed so that nobody could tell who the perpetrator was, who the reporter was, or what the organization was. Then we chose 5 of those people, and they gave their stories right before at least the House Judiciary. And one was particularly compelling that I'd like to share with you. It was a girl that was working on the Eastern Shore, and she had a female patient come in who was trying to take her meth right in front of this nurse. And the nurse tried to convince her, no, I don't want you to take that right now. You're already pretty altered. Please don't do this. And this patient shoved her and she went across the room. And then this patient decided to just beat her up, And this nurse decided to press charges. And when she had the police come into the ER and say, I'm pressing charges against this one right here, right now, this patient, who was now even higher on meth, made this terrible threat to her that a lot of patients do. I'm going to find you and I'm going to kill you. And you better take this seriously. I am going to find you. And so this nurse was just shaken to the bone. It turns out she's an identical twin. And she was so fearful that this patient was going to come and find her twin and kill her twin. And so she followed through with filing charges. And while she was sitting in the courtroom, she saw this patient who didn't recognize her because the nurse was in civvies, not in scrubs. And she overheard the patient and this patient's lawyer talking. And the lawyer was advising her, oh, you don't have to worry about the charge against the nurse. That doesn't matter. The nurses don't matter. It's just a misdemeanor to assault a nurse in Maryland. What you have to worry about is that you assaulted the police. This strong nurse went and found I think it was the assistant district attorney, and she relayed this conversation. And so a big deal was made about this in the courtroom, about overhearing this, and they allowed this nurse to speak about how she had been just living in terror, and she had even her sister and all her kids and her parents, be on the lookout. And we had thought that maybe this would move the legislators to, feel it. They didn't. So that's one of the more compelling stories we have.
Thank you, Lisa.
So I wanted to report in, there's going to be a new state's attorney in Baltimore City. Ivan Bates beat out Marilyn Mosby. And one of our hospital presidents had Mr. Bates out this week. And we were describing this problem because of the reluctance of prosecutors to prosecute these cases. And Ivan Bates was appalled at what he heard. He had no idea this was an issue, none. And these are the people that would be responsible for prosecuting. So I just bring this up. And by the way, he said, bring me a good case and I'll send a message. So that was encouraging. But this public awareness campaign could also inform people like the state's attorney's offices that need to really take this seriously as well.
Thank you, Peggy. And again, the stories are important. They connect with people, and that can help with the public awareness campaign, that to connect with people to understand how serious an issue this is. I think that's really important. Anyone else? So we've got, you know, a timeline here for our work. And a couple of, we're going to need to make sure that crafting a campaign like this, I mean, again, we've got experts who do work like this. And again, Maryland Public TV has offered their assistance with this. And they do most of the state's public awareness and public relations campaigns already. So I can't speak for the Healthcare Commission or the department, whether Maryland Public TV would be doing this campaign, but I can tell you it's unlikely. So that their help is greatly appreciated as we move forward. But we need to, you know, to put this together in a relatively short time period. We're pretty sure we're going to get an extension, and so we had tentatively scheduled a meeting in 2 weeks, just because, but which is a short time period to put together anything, I realize. But what we're hoping is to be able to extend that out a month to give our communications experts some time to put something together for us to react to. But we're going to need each of your help. There's a lot of things to consider here. We've talked about this to some degree. What is our target audience for this campaign? Is it everyone in Maryland? Is it the patients? Is it families? Is it the healthcare workers? And probably the answer is all. But that's going to have, you know, as you craft a message or multiple messages, that's a very important part of this. And the sensitivity that we have to have, and it's already been mentioned by several of the presenters in terms of the sensitivity around, well, go back to the data that Mark presented. For at least patients, there's a high degree of behavioral health disorders associated with this, as there is substance use disorders. And also delirium associated especially with age. And nobody wants to scapegoat or, you know, pick a specific disorder and say it's their fault. We realize that. But we do have to address the issue of violence and abuse of healthcare workers, and we need to address that with that sensitivity. There's also the issue of, and this has also been mentioned, that we don't want to make emergency rooms especially look so violent that we are scaring away patients or we're scaring away potential healthcare workers. That's obviously important to all of us here. So we need to create, the campaign will have to be carefully crafted in that. What I'm asking, I guess, is for all of the indulgence of our communications team to be able to reach out to you, or myself and the Healthcare Commission team to reach out to you, to bounce specific ideas or thoughts off of you, to get your ideas and to get your input, especially in reaction to some of these sensitive issues. Does that sound reasonable? Is that okay? Anybody have any questions about what I just said?
I think that sounds right. If maybe it's a subcommittee of this committee, which is the communications folks, and maybe they could meet and maybe, you know, give us a couple of themes or messages that we could react to for our next meeting.
Yeah. And I've already talked with Matt and Amy and Anna. I apologize, Maggie. I haven't talked to you, but I would hope you'd be able to help us here. In terms of, working on the side to be able to develop this, and then again, working with our, the team at MPT for any just input they can provide us so that we can get this developed. We hopefully will have more time to be able to do this. The Healthcare Commission staff will be in touch with you about when the next meeting is, right, Teresa, I guess, when we know what our time frame is.
Yeah, Blair, we do have like 2 possible dates you and I talked about. If we skip October 12th and have a tentative date for October 26th, which is a Wednesday, 4 to 6, if that date would work. And that is dependent upon the groups being able to put something together for this committee to respond to by then.
Yeah.
You think?
Yes, and that if we get the extension, which again, Senator Kelly from the Senate Finance Committee has already approved. We just haven't heard, I think, from Delegate Pena-Melnick back from the House and Government Operations Committee. I imagine she would be quite amenable to a 1-month extension, and I might just turn that over to Begin to talk to her about that. But the idea would be, if we have that time, it gives them more time, us more time to contribute. And the goal would be to have something to react to in 4 weeks. And then we'd have time after that for a final plan to come back to a 3rd meeting of this committee sometime in, let's say, mid-November, to be able to have plenty of time to submit it to the legislature by a December 1st deadline. So that would be the goal. Any questions?
Do we want to not have to hold the tentative October 26th at this point, or?
I'd rather hear that we have the extension first. The concern would be if, I can't imagine Delegate Pena-Melnick not approving that, but we probably need to officially hear back from her before we release that time. That's all I got. That's
So,
and I am not the expert on the legislature.
right, no, I get it. I'm just trying to, so if for some reason we didn't get it, that's why I'm saying, do you want to have those placeholder dates?
But we can have the placeholder
as a placeholder date.
Yeah.
So that we can hold it, but it's very likely if we get the extension that we can modify that to give the group more time to come up with something.
I would tell the committee, keep the 12th open if you can, but expect pretty sure that we will be able to cancel that and next meet on the 26th. If we did get the extension, we'd probably have to do both of those meetings just to get it in time. But again, we're very much expecting the extension. Tracy, you put something in chat. Did you want to say?
Yes, you actually have the extension.
Oh, okay.
It's fine. Yeah.
Oh, good. Yeah. I should have gone to you first, Tracy, since you.
That's okay.
And so we do have the extension. So no meeting on the 12th. Our next meeting would be the 26th, 4 weeks from now. And just please be prepared to be reached out to. Your feedback from all of your expertise, and this is a wide range of expertise. We all realize how crucial an issue this is. We realize that in the grand scheme of things, this may seem like a small step, but the ability to be a squeaky wheel or rattling the cage, or whatever analogy you want to use, is important here, because the awareness is very important for the public, for the healthcare workers we're trying to support, and for the legislators and everybody else out there. And that's what we're hoping to be the ultimate outcome of this, is to make everybody aware and work harder on this. So I don't have any more for this meeting. Again, you'll get the presentations will be sent to you all. soon. Is there anything else from the Healthcare Commission staff that we need to wrap up?
Just want to follow up with Courtney mentioned, we are going to create on our main website a page where you'll be able to access information. So that will help too. And as soon as that's available, we'll send out a notice to work group members.
Teresa and Dr. Ige, I think Dr. Levy and Lorraine had their hands up at some
Oh,
point.
I'm sorry. Go ahead. Start with Dr. Levy, I guess.
Sure, thank you. It's probably a little delayed now, but just want to echo everyone's comments and just how important this work is. I would just implore upon us to think about each of us come from a certain perspective and through a certain lens. For those of us who are clinicians and have had clinical roles, I would venture to say every single one of us has probably witnessed or been part of an act of violence in our careers. Dr. Ige, your question made me pause and think. And I just want to share my answer with you. The first time I was assaulted as a healthcare provider, I was a 16-year-old EMT on an ambulance. And so that's been the first of many. We have a tremendous uphill challenge here because it is endemic violence. And so I think this is going to be a journey, not a destination. I'm privileged to be part of it and want to be able to speak for the voice of our EMS clinicians as well as the voice of our emergency department staff. So thank you guys very much. I look forward to collaborating with everybody.
Thank you for that, Matthew. And Lorraine, did you have something to add?
Yeah, I really appreciated the stories that are being shared. And I just wanted to respond to one of the comments regarding, I think, raising up and hearing about how violence to healthcare workers is a misdemeanor in Maryland. I just wanted to clarify that if a communications campaign is around raising awareness about that specific situation of, should it be raised to a felony is different than a communications campaign for violence prevention at the workplace. And also what Dr. Levy just mentioned, violence prevention at the workplace for healthcare workers is also going to extend to violence prevention in the communities, right? Like how are we making our patients and workers safe so that communities are safer too? So I just wanted to kind of clarify that it would be important to separate those two messaging campaigns because I think it is two different issues.
Thank you, Lorraine. Absolutely. This is a workplace violence awareness campaign. It is not for specific legislation regarding felonies and misdemeanors, even though, we all may have opinions about that. And it may raise awareness enough to get people involved in the, that legislation, but it is not. You're absolutely right. This is a separate issue for this work group. But thank you. And your comment about it's not just in hospitals, even though that's where we focus a lot of this. It is in the community. It is in long-term care. It is in clinics. It's for visiting health workers across the state. It is all of that. And thank you to Dr. Levy about representing EMS because it's them too. So thanks. Anybody else? Did I miss any other raised hands? I'm not good at raised hands. It's just me. So if not, thank you all. This was great. It's a great start. I'm kind of already sad that we're only going to probably meet 3 times. But we will probably engage you all in development of this campaign. We will probably engage you all in lobbying the legislature to fund it after it is submitted to them. And then in spreading it around the state. You all come from, again, across the spectrum and have various constituencies, which is fabulous. And a way to help us reach out to make this awareness campaign effective. So again, thank you. Thank you to the Healthcare Commission staff. Thank you to our speakers today. And if we don't talk again directly, even though I said you're going to be reached out to, we'll meet again in 4 weeks. Thank you.
Thank you.
Thanks, everyone.
Leave meeting again?